Good afternoon, everybody. I'm Swathi Sethuram. I'm a pediatric endocrinologist at Mass General, and I work with Dr. Eichler in the leukodystrophy clinic to see ALD patients. We take care of children in our clinic primarily, and this is my email. If any of you wants to contact me after this, I'm happy to always collaborate with you, with your local endocrinologists, and I have no disclosures. My focus for today is really going to be helping you understand why the adrenal glands are important for us, how we endocrinologists diagnose adrenal insufficiency or AI, and how we treat it. So I'm sure a lot of you are familiar with this. The adrenal glands are also called the suprarenal glands. They sit right above our kidneys in our abdomen, and they're really tiny structures. They just weigh 4 grams each, and they are vital. We cannot live without our adrenals or the hormones that they produce. The adrenal glands are really divided into 2 parts. The inner portion is called the medulla, which makes adrenaline, and hence the name adrenal glands, and the cortex, which makes the steroid hormones, and it makes many of those steroid hormones. In ALD, we primarily focus on that adrenal cortex, and I'm going to spend a little bit of time on this slide because I think it's important to understand what the adrenal gland does. So the cortex makes many different steroids. The first group is called the mineralocorticoids. I just want to familiarize you with terms that your endocrinologists may use, just for you to understand. The primary mineralocorticoid is aldosterone. And what this does is it helps hold on to the salt or sodium in your body. And the synthetic form of aldosterone is fludrocortisone. What happens is that with changes in our body's hydration or sodium status, aldosterone is produced either in higher or lower amounts, and this is controlled by another hormone called renin, which comes from the kidneys. So renin stimulates your adrenals to make aldosterone. This becomes important to understand because with any issue that the adrenal gland, like in ALD, may not produce these hormones, there is always a feedback or a cycle mechanism where when one hormone isn't produced, the other one kind of goes into overdrive, and that's what your endocrinologists measure in our patients. The glucocorticoids are another very important set of steroids, the most important being cortisol, and the synthetic version is hydrocortisone and others, which I'll come to in a minute. And sex steroids are also produced by the adrenal glands, like DHEA and testosterone. Now, sex steroids are obviously also produced by our gonads, like the ovaries and the testes, but the adrenal glands are also important for that. Now, these 2 parts of the adrenal steroids are controlled by ACTH, or adrenocorticotropic hormone, that comes from our pituitary gland in the brain. And again, when the adrenal glands are not able to make cortisol, your ACTH goes into overdrive and starts to produce a lot of it. And one of the features of that is with higher ACTH, you see higher melanin or pigment on your skin. So kids get a tanned appearance, may have dark lips, dark nipples or private parts, which can happen because of the higher ACTH. Cortisol as such has many different functions, but I think what I want to focus on is what happens when you don't make cortisol, because this is what you are looking for as parents. Low cortisol can cause low blood sugars, it can cause low blood pressure, and it can cause low sodium levels. What that means is that your children could feel very tired, there may be weight loss, there may be poor growth, nausea, vomiting, belly discomfort, mood changes. Some of these are pretty vague, so it's not always obvious that this is because of adrenal insufficiency, and this may develop over weeks or months, so it's not always an immediate, urgent reaction that occurs, but something you want to watch for. An adrenal crisis is always dreaded, right? And it's something that our goal as endocrinologists is to avoid them. And we define adrenal crisis as when there is hypoglycemia and or hypotension or low blood pressure due to cortisol deficiency. Obviously, it is a life-threatening condition. And there are many different triggers to this. Any sort of illness, fevers, vomiting and diarrhea, trauma, fractures, surgery and anesthesia. Anesthesia becomes important in children getting sedated for MRIs. Missing daily doses of steroids, lack of stress dosing when sick, all of these are triggers for an adrenal crisis. Now, this is a controversial statement probably in this scenario, but mental stress is not thought to cause an adrenal crisis. Of course, there may be anecdotal experiences where that has not been the case, but typically there is just not enough data for us to say that anxiety or mental stress will lead to an adrenal crisis. ALD and the adrenal gland are obviously very, very intertwined, and again, it goes back to the basics of accumulation of the very long-chain fatty acids. Adrenal insufficiency typically in ALD is restricted to some extent to the cortisol production, although the other portions like the mineralocorticoids or sex steroids can be affected. The diagnosis is really made by endocrinologists by biochemical testing. So we do recommend urgent pediatric endocrine referrals. The ACTH and cortisol are what are usually measured as first line. And then really based on the levels of the ACTH and cortisol, your endocrinologist will decide whether further testing is necessary or not. These are based on the Pediatric Endocrine Society 2018 guidelines for adrenal insufficiency in asymptomatic patients. And the second line of testing when our labs show borderline levels is ACTH stimulation tests, where your children will be given a synthetic ACTH to see whether their body is able to make cortisol. And the more cortisol you make, the better it is. Our cutoff is usually 15. So if your child makes a cortisol of more than 15, we think that that's adequate. But when they're not making enough baseline or those stimulated cortisols, we either decide to give just stress dosing, steroids, or daily hydrocortisone with stress dosing versus no treatment. But regardless, surveillance is very important for these patients, where laboratory evaluation is recommended every 3 to 4 months in the first 2 years of life, and then every 4 to 6 months. Renin and chemistry profiles are also recommended every 6 months to diagnose mineralocorticoid deficiency. Treatment. In endocrine, when you're not making a hormone, treatment is typically just replacing. So we give back those corticosteroids that the child's body isn't making, usually 2 to 3 times a day. Pediatric patients do have different doses based on their weight and height. We calculate based on body surface area, so this is constantly obviously changing. And stress dosing becomes extremely important because typically when you have adequate adrenal function, your body is able to increase its cortisol production, whereas in adrenal insufficiency, this is not possible. So you need to administer extra corticosteroids to help deal with that stress of an illness. And typically it's double or triple the dose every 6 hours. And it's given for about 24 hours until after the symptoms have resolved or based on the endocrinologist's discretion. But what I tell my patients and families is that when in doubt, stress dose, because that can prevent an adrenal crisis. And also ask for an adrenal action plan. This is really just a plan that your endocrinologist can give you in writing, telling you what the daily dosing is, what the stress dosing is, what to do in terms of, in case of an emergency and for procedures. in writing so that if you need to go to the emergency room, you can just hand them this sort of paper or plan. Always, I always emphasize that wearing a medical alert bracelet can be life-saving. All patients with adrenal insufficiency should be wearing one. Now, fludrocortisone is also sometimes used for replacement purposes when there is mineralocorticoid deficiency. The steroids that we use is typically hydrocortisone, and this is preferred in pediatric patients because it is most physiological and it has lesser side effects, but it has to be given at least 3 times a day typically, and only tablets and sprinkles are preferred. Liquid formulations are not preferred because they're not very stable and they need to be shaken for literally 1 minute before administering, which is not really practical. Adults and adolescents, after they're done growing, can sometimes use prednisone, methylprednisone, or dexamethasone. The emergency Solucortef injection is really used only in terms of dire emergencies. We prefer that most patients, even in an adrenal crisis, if able to take orally, can take extra pills. But if needed, you should always have this emergency injection. We prefer that the active vial is what patients have because that contains the diluent and the powder in the same vial. Again, the dose is age dependent, and you also want to look at the formulation you have because there are different formulations, which will mean that you may need to give different amounts of the medication, and needle sizes do vary by age. These are usually intramuscular injections in children, but there have been reports of adults using them subcutaneously, so just under the skin with small needles, and they have been quite effective. So ultimately, the needle size may not be as big a deal, but it is important to look into. For the future, there may be some hope because there is a study by a company for an auto-injector like EpiPen, but it's in very, very early stages, so we will have to wait and see what comes out of that. I have just put in 2 references for you to see because I think I heard a lot about how difficult it is to understand how to give these shots. The Children's Hospital of Philadelphia has a nice video on it, and Sloan Kettering Cancer Center in New York also has this PDF with really step-by-step instructions, which include like pictures. So I find that very helpful, and I give that to most of my patients. And I feel like this is less talked about post-AI monitoring, because once you have AI, we don't really do much, but we do. Kids need to continue seeing their endocrinologists. We prefer clinical monitoring over everything else because it really tells us what's going on. We look at weight, we look at growth, and other symptoms of adrenal insufficiency. Biochemical monitoring is primarily use of the chemistry panels and renin. ACTH monitoring once on daily steroids may be a little controversial. A lot of people do it, but what is important to remember is we do not expect completely normal ACTH levels. Having completely normal levels or low normal levels may indicate overcorrection. In autoimmune Addison's disease, we don't typically monitor ACTH because this is just going to make us chase labs while the patient is clinically feeling okay. So that's just something to remember. And of course, with overdosing because of maybe abnormal ACTH, there can be consequences like weight gain, poor growth, hypertension, diabetes, muscle wasting, mood changes, and many more. So we have to balance the benefits and the risks of treatment. And then I'll finish with just a few things to consider or think about. There are other endocrine aspects in ALD to consider, like hypogonadism. This isn't very prevalent in pediatric patients, but it has been described in adult males. But the recent international consensus recommended against screening, which because of the lack of evidence, and treatment is only indicated based on an endocrinology evaluation. And then I think we will be talking about this more in the future is post-bone marrow transplant and what other endocrine evaluations need to be done, which include growth, thyroid hormones, and puberty and gonadal function, which is also important to consider. And I will end with this and allow Dr. Ramirez to continue.
All right, so I'm Dr. Jonanlis Ramirez, and I was a pediatric fellow at Mass General, and this is where I had the great opportunity of being involved in this project. And currently, I'm going to be practicing as an attending physician in Florida. But what I'm going to be talking about today is about what has happened after the newborn screening has been implemented with regards to adrenal insufficiency. So just as a little bit of a background, the New York was the first state that started to test for ALD in 2013. In 2016, the testing for ALD in the newborn screening was added to the recommended uniform screening panel. And in 2018 is when the pilot for the newborn screening for ALD was started in Massachusetts. So this map was actually from 2 days ago, so hopefully they didn't change it yesterday. ALD has been tested in around 30 states and Washington, D.C. And what we're seeing is that seeing the data from different states, the incidence of ALD is very wide depending on where you see it from. So it goes from 1 to every 4,845 births to 1 to 17,000. That was in comparing New York with Minnesota. So following the same line that Dr. Sethuram was mentioning, we used the guidelines of 2018 to guide how we did this study. So what we did was we set out to investigate whether the newborn screening has altered the time to diagnosis and overall clinical care in patients with ALD that have adrenal insufficiency. So what we did was we did a retrospective medical chart review from 2006 to January 2022. We included 116 patients with ALD from 0 to 17 years of age. 94% of them were males. We divided it in two groups. 27% were diagnosed by newborn screening and the rest outside the newborn period. And as you can see, there's a difference in the ages. So the newborn screening group was, the median age was 11 days compared to the other group that was around 5 years. And that was statistically significant. So this chart talks about the impact of the newborn screening about the age of diagnosis of ALD. So if we take the blue bars, talk about diagnosis of ALD in the first year of life. So around here is when the newborn screening started in New York. And you can see that there is an increase in diagnosis of ALD in the first year of life. And this is where the newborn screening started the pilot in Massachusetts. So the reason why I mentioned Massachusetts is because most of our patients were diagnosed in the northeast of the United States. With regards to the patients that were diagnosed outside the newborn period, so what we found is that there were 3 different ways that people got to the diagnosis of ALD. So those were after having neurological symptoms, either a family member that was screened and was diagnosed with ALD, or if you were diagnosed with adrenal insufficiency and that led to the diagnosis of ALD. So I want to point out in the bottom left that we found that there were 6 patients that their diagnosis of ALD was due because a family member was diagnosed with ALD by newborn screening. And the second thing that I want to point out is we actually looked at this particular group of patients that had adrenal insufficiency diagnosed first and then ALD. And what we saw in their charts, only for 11 of them, is that when you look at all of the times that the patients either went to the doctors or the emergency room, is that 9 of them presented with suspected adrenal crisis when they were diagnosed with adrenal insufficiency. And 2 of them had symptoms that when you read it, it's actually this patient could have had adrenal insufficiency and maybe no one picked it up because as Dr. Sethuram mentioned, sometimes the symptoms are not, as specific. So for the 9 patients that had the suspected adrenal crisis, 1 patient actually presented with cardiac arrest at the time of adrenal insufficiency diagnosis, and all of them had several episodes that when you look back at them, you're saying this patient was probably having an adrenal crisis at that time. So from our whole cohort, we had 70% of our patients had adrenal insufficiency. All of them were boys. And we have 10 patients in the newborn screening group, and the other ones were outside the newborn period. But what we sorry. What we found is that the age of diagnosis of adrenal insufficiency was actually very different. So we are talking about 6.7 months versus 6 years. And this was statistically significant about the age of diagnosis of adrenal insufficiency. We also classified the diagnosis of adrenal insufficiency. Either you had we call it latent, just because we found that in the charts of the patients, they had abnormal labs that said that they had adrenal insufficiency, but we couldn't find any evidence of symptoms. So the youngest patient diagnosed was done at 2 months of age. And then the earliest symptomatic patient was diagnosed at 3 months of age. If you see this graph, this is talking about peak cortisol level. So why do we care about this? So when we do an ACTH stimulation testing, we want to know how high your cortisol levels are. So meaning, when we give this ACTH, the higher your level, the better your adrenal function. So what we found is that when patients were started on maintenance dose, patients diagnosed by newborn screening had higher peak cortisol levels compared to the other group. But the opposite happens when we're talking about ACTH. So if you have a higher ACTH, meaning that your body is trying to compensate for that lack of cortisol that you're not able to make. So we found that when the patients were started on maintenance dose, patients diagnosed outside the newborn period actually had higher ACTH level. And I'm not sure if you're able to see it, but there's like a point all the way on the right side that is almost 7,000. So, and our cutoff is around like 300, give or take, like you see the line. So you see that at least that patient had a very severe adrenal insufficiency. So the other thing is, what happened, we looked at when was the treatment of adrenal insufficiency started. And the ones in green talk about patients in the newborn screening group. The blue is the outside the newborn period. So patients in the newborn screening group, when they were started on stress dosing and maintenance doses, they were started around 6 and 9 months of age, like that's the median, compared to the other group that was around 5 or 6 years. And that was statistically significant as well. So some of the points that we wanted to make with this study is that diagnosing ALD by newborn screening does affect the diagnosis and treatment of adrenal insufficiency. It will lead to significantly earlier adrenal insufficiency diagnosis, and patients seem to have a better adrenal function at the time that they're diagnosed with adrenal insufficiency if they were diagnosed by newborn screening. As well, having those early diagnoses of adrenal insufficiency around 2 and 3 months of age further supports the rationale of having like the ALD tested in the newborn screening, and the need for having an early and vigilant screening for adrenal insufficiency in children who have ALD. The other thing is that seeing all of these patients, the patients that were diagnosed outside the newborn period that had supposedly adrenal crisis, we see that there is a burden of symptom manifestations in the patients that are diagnosed outside the newborn period. Also, none of the patients diagnosed with ALD by newborn screening had adrenal crisis to date. And this further supports the importance of diagnosing ALD early to prevent adrenal crisis. So we conclude with this, that our results suggest that ALD implementation as a part of the newborn screening leads to significantly earlier adrenal insufficiency detection and initiation of glucocorticoid supplementation. Considering these findings, ALD should improve care and clinical outcomes for patients with ALD and adrenal insufficiency across the United States. And we also hope that this study can help us get the ALD testing and the newborn screening across the United States. I want to make an acknowledgement, especially to Dr. Eichler, who was my research mentor, my co-mentors, and Natalie, who gave a wonderful presentation this morning, and my co-authors, including Dr. Sethuram, for this study. Thank you.
Thank you very much. That was great. Maybe some time for questions for both speakers. You can come to the front. You go ahead.
Have you seen any correlation with flying and adrenal crises, especially in children?
I have not seen any of that. Have you?
No, I don't think travel as such has been noted to be a trigger.
I'm just asking because every time we fly, we have crises. So
Interesting.
Interesting.
Okay. Any other questions?
I think there's a question over there.
Oh, I can her first.
So in terms of steroid dependency and supplementation, how would you recommend mitigating the adverse effects like Cushing's and skin thinning when you're taking steroids 3 times a day?
I can answer that if you want.
Okay.
So I think it's not about taking the steroids 3 times a day. It's about your total dose that you do in a 24-hour, and that's the reason why we monitor and see, like, because we're pediatricians, right? We see the weight of the patients and we make sure that they're within what we call physiologic dosing. So if all of that is okay, it's very unlikely that you're gonna develop like those side effects.
I agree. And in addition to that, I think that's why in pediatrics, at least, we prefer hydrocortisone because it's less strong or potent and less likely to produce Cushing's. But I agree that it's really the total dose of the medication more than 3 times a day or 5 times a day.
Okay, I have two parts. One is a public service announcement, kind of speak, for all parents of young children, and that cannot obviously give themselves, the intramuscular injection or any adults or whatnot, to know what your policy in your area, your local hospital, with regard to an ambulance being called on the scene. Because they are in charge. Once they're on the scene, they're in charge. I had this when my child was 5 years old. He was in school. He was starting to have a crisis. I was called. I got there at the same time as the ambulance. And the school nurse was drawing up the Sawyer test, and I was there and ready to give it to him. And they stopped her and said, "What is this?" Told him what it was. He had adrenal insufficiency. And they said, "No, he cannot have that. We are in charge." Long story short, my child went from apologizing to me, "Mom, I threw up all over my shoes, my new shoes." And I could see him going down, and he eventually went into almost a comatose state and in the hospital. And when we got to the hospital, in the meantime, I was calling my endocrinologist. She said, when you get to the hospital, tell him he has adrenal insufficiency at the top of your lungs, and he needs stress dose steroids, which I did, because everybody was looking at the ALD diagnosis rather than the adrenal insufficiency, and I had a group of doctors. But anyway, they did give him, but he was still, the Sawyer test, but he was still seizing, and then he stopped, but they intubated him. And my son woke up. My son woke up when they were intubating him. It was like crazy, these things. But what I'm saying is that different hospitals, different areas have different protocols. And that was my area. And today, they will not, they refuse. But I do have the ambulance, if it's ever called. My son had crisis, maybe yearly. Thankfully, he hasn't had it for a couple of years. But they will come on the scene. They will even draw up the needle for me. But they'll let me give it to him, It's just one of those things. It's considered a home med. That was my public service announcement.
Yeah, no, I think it's very important you brought that up because pediatric endocrinologists are aware of this because it's very local, and every district, I think, is really has its own policy on Sollicort-F. A lot of some places, the paramedics don't even carry Sollicort-F as an emergency shot, and then they won't give the home medication. But this is obviously very life-threatening. I work with the Pediatric Endocrine Society as well, with the Public Policy Committee, and this is one of the goals on our agenda to help nationally get Sollicort-F for everybody.
That was one. Number two is I just want everybody to be aware that when my son had a major growth spurt 2 years ago, and he was very poorly, and we were addressing it, taking him to the doctor. They couldn't find, all his levels were borderline. They weren't anything significant. And plus, he couldn't, in school, he was actually collapsing. They had him in a wheelchair. And we take him to the emergency room, take him to the doctors, and couldn't really find anything wrong. In the meantime, because he was acting poorly, I was stress dosing him all the time. And I did this over a period of a couple of months. And we couldn't figure it out. He was even losing weight. He lost 10 pounds in 8 days. Wow. And he was he went to Children's Hospital in Philadelphia, and they couldn't even find out what was wrong. Long story short, shortly after around January, it was like 2 months, and he was a day off school because it was a snow day, and he had a grand mal seizure. And he was unresponsive for 10 days, but thankfully he's doing okay now. But what happened, I believe, is that his meds didn't catch up to him. And because I was stress dosing him intermittently, it kind of staved off the inevitable, but his body couldn't handle the stress anymore. So that's another thing that it was never mentioned to us. I see that you had it on the slide here, but I just want to reiterate it, that watch out for that. He was on the same dose pretty much all the time, but then he just, it was around, he was 13 years old. So just something
Thank
to
you. We got
watch
to
out.
move on, I think. Thank you very much. Yeah. We're running a little behind, so maybe after the session, we definitely have the opportunity to have more questions for the speakers. Thank you all.